I'm in Max Anamti right now. Is it coming? Right. So TMH is my claim to fame, as Ullas rightly said. It's very easy to deliver a talk after 1 hour of Ullas. My things are pretty simple. Either you chop it out or you can't. So I'm going to speak about how you incorporate surgery in this era of immunotherapy and total DKIs and multiple other treatments. I'm sure there are no surgeons in this territory, so there's not going to be much objection on surgery about what I'm going to speak about. So this is how we're going to go. First is we have to define what exactly is a locally advanced disease, how the treatment has evolved in the last few years, and the principles of treatment right now, and the technical issues which surgeons face when we are treating a patient who's received multiple lines of immunotherapy or even fertility care. So this is the classical definition of lung cancer. I'm sure everyone's gone through it: early stage lung cancer, locally advanced lung cancer, and metastatic lung cancer. And what is classically defined as locally advanced is stage 3A to 3C. Very simple, but in my mind quite arbitrary how we decide that this is locally advanced lung cancer. So if you look at the latest immunotherapy trials, even from Keynote to Pacific, you will see that early stage, surprisingly, is in the Keynote trials defined anything from resectable stage 1 to 3B. That means stage 3B is also included as locally early stage. And what is defined as locally advanced in the Pacific trial is unresectable. So what you find the common feature in this is they look at whether it is resectable to define whether it is early stage or locally advanced. So I think it's an incorrect marker to say define something as locally advanced and then decide. So if you look at all the immuno trials which have come up, the nivolumab, nivolumab, atezolizumab, every one has looked at resectability as what's going to decide how you're going to decide treatment. So for a surgeon it's easy. If I ask any one of my students what is the definition of what is T1 to T2 to T3, none of my residents know, because ISLC comes with 7, 8, 9, nobody knows. But if you ask him whether it's resectable, any surgeon with a further solve will tell you, okay, I can take this out, I can't take this out. So it's easier for a surgeon to understand and incorporate this practice. But would you leave a surgeon alone to decide resectability? I wouldn't trust a surgeon. I had a boss in Tata who used to say, unless it's stuck to the table, this is going to come out. So for resectability, I think you should always circulate in an MDT before you decide, okay, this patient is resectable, at least you will locally advance whichever and decide on the original treatment if required. And it's not surgeons alone speaking. This is in the URTC. They looked at stage 2, stage 3 particularly with whole disease to decide. And surprisingly, they are not talking in terms of locally advanced disease here. They are looking at resectable, potentially resectable, and unresectable. And this came out in the ISLC last year in Singapore. And what I like best as a surgeon is this is hotly debated earlier that 3A disease or 3 should be operated at all. And in this one, it came out as single stage is definitely resectable and multi-stage is potentially resectable. This is a sea change from what was discussed earlier. So things were simple a few years back, 15 years back, when I started off this thing in lung cancer, it was very simple. If I resected a lung cancer, if it was more than 4 centimeters or any node positive, I would give adjuvant chemo. There was no oral TKI or immunotherapy at that point. If it was single station NQ, because I've done more than 1,000 various studies. We found any node positive, we give neoadjuvant treatment and then operate. Multi-station, I would do chemoradiation. Although I was a proponent of operating, I wanted to operate, but we were forced by the guidelines to give chemoradiation. And with entry, it's chemoradiation, definitely. But it was hotly debated. I'm sure there's a lot of radiation on this year, so they would say, okay, let's chemoradiation is the way to go, or even neoadjuvant chemoradiation is the way to go. But the fact of the matter is, this is the ground reality. This is the NCCN guidelines in the practice patterns survey. And they found that in N2 single station, virtually 100% of patients will offer surgery. If it's multi-station and non-bulky resectable, 39% included surgery in the total treatment algorithm. And when you give neoadjuvant treatment, 67% is neoadjuvant chemotherapy. But unfortunately, the results were not great. So if we had a locally advanced disease, which was even included surgery, this is the survival you could get with the first 2 trials are neoadjuvant chemoradiation trials, 23 months, that's not great. And with chemotherapy, it is hardly 21 months. So this is the median OS you could get. So when you did the first 150 cases in Karimundackal after neoadjuvant chemotherapy for N2 resectable disease, we did an analysis. We found that the median OS is 42 months. That's probably because our surgical criteria were tighter. But 42 months is all we could achieve. And surprisingly, most of the recurrences were not locally or locally in the media center, most of them were systemic. So that means that we need better systemic treatment than a more advanced local treatment like surgery or even radiation. So in this field where we are looking at, we wanted to prevent systemic recurrence, step and messiah, it's almost like a messiah has come. Initial reports were very encouraging. I once had one of my relatives was the first patient in Tata to go on a Immunotherapy trial. He lived for 7 years. So we expected a lot. So it came initially in the metastatic setting, which we have seen discussed here. Then the adjuvant setting, then the neoadjuvant setting, and now it's getting into the peri-op setting, where they're getting it before and after surgery. So I won't go through all these trials. This is the first one which came out. This is the adjuvant atezolizumab trial which came out, where we resected, and if they're PD-L1 positive, you say I have exactly 2 patients on it. The results are not great. The DFS improvement, if you look at the HR, is 0.81. So the moment is closer to unity, I'm a little bit doubtful about the clinical significance of it. And it only showed an improvement in overall DFS, not in OS. So not many, I have only 2 patients on this one. What is more encouraging was what we found in the neoadjuvant setting, because I compulsorily give neoadjuvant chemotherapy for any patient who is N2. So when the Nadeem trial came out, it was really encouraging, and it actually showed a 3-year OS of 31.9%. And this is the only trial which actually showed an OS advantage. So this is the keynote trial. Again, event-free survival is a benchmark they're looking at. For a surgeon who looks at a trial, it's very important, to have a recognizable, understandable endpoint. For him, it's simple. If the patient lives longer, OS is better. But if you look at all the new trials, you find EFS, you find DFS, it's actually quite difficult to decipher and even to compare across trials. But this one had a significant improvement in event-free survival with an HR of 0.58. After the encouragement, only thing is I want you to look closely at this graph. This one shows that if the effect was much more when you gave it in stage 3A, when you gave it in stage 1 or 2, the hazard ratio was 0.87. That's closer to unity. So the effect was not significant when you gave it in early stage. This is a number I want you to hold in mind. So with encouraging results in neoadjuvant therapy, the next step was giving peri-op. This came with the topoisomerab, again significantly improved responses, HR of 0.68, and another one with pembrolizumab, again HR of 0.58. So all really good results, and showing, stage 3 was something which we are hesitant about operating in the first place. When we get good results with good control, we are all really happy. So with all these encouraging results, how do you incorporate each one into your practice is the question. So what we know for sure is that the response is fantastic. So this is one of the issues as a surgeon which I face. This patient had, this is one of the things that she had, she was EGFR positive. The medical oncologist actually did not wait for the EGFR and treat her with the immuno. Then after the first cycle, okay, let's stop the immuno, we give chemo. But the response is fantastic. So now I don't know what has worked in whether it's a immuno or a chemo, but the patient comes back to me, she's got a tiny lesion. This is one of the problems, they ask the question, do I really need surgery at this point? So you're not really sure, because PCR is very rare. So ultimately the lady was convinced for surgery and she underwent surgery. So we get excellent responses, but very little OS data. So I'm not sure whether they actually go to live long or it's just a DFS. The varying endpoints make it difficult for me to decide whether it's neoadjuvant, adjuvant or perioperative. And the sequencing is very difficult to convince a patient, because you can't compare across trials also, because each trial has got DFS or DFS as an endpoint. Now, based on all this data, I made my life very simple. I use it primarily in the neoadjuvant setting. The keynote is what I go for multiple reasons. If it's a resectable N2 on the scan, I get together the NPT, we have an NPT, and we go for neoadjuvant therapy as far as possible. The reason I like it is because in 3 cycles, less cost and shorter duration of treatment, and the patient is interested in a shorter duration of treatment. We had discussions about where to use media not really understand. So these are the indications for neoadjuvant treatment for me. A resectable N2 disease, whether it's single station or multi-station, I would go for this. If it's borderline resectable where I find it can't resect, but at some point with a response I will use this. And to downsize to avoid an immunotherapy. In the words of a friend of mine who is Japanese, says, immunotherapy is a disease. It causes so much morbidity that you should consider it a disease and avoid it as far as possible. So if I can do a lesser surgery, that is a locatomy, I would definitely try neoadjuvant. Now I put a next point in gray because it's a gray area for me. So when I do the surgery and I find a patient who is stage 2, usually anything more than 4 centimeters or more positive, after the standard chemotherapy, should you give atezolizumab? I'm not really certain. So it's a really gray area, particularly because the hazard ratio for DFS is 0.81. Now the strange thing is, why is the patient asking me? Usually I didn't go to the medical oncologist, and the medical oncologist makes a decision. But in Bombay particularly, they always have a habit of coming to the primary physician. And I just said, this is the numbers, please consult your medical oncologist for further details. Now even more of a gray zone is lesions which you see on a scan, which are 4 centimeters in size, have a hilar lymph, are clearly resectable. So resectable, stage 2. The standard treatment for the last 17 years, I just taken up from surgery, just done an EBUS or radioscopy. If it's negative, surgery. Now the question, because every trial has included stage 2 to 3A, is would this group also benefit by giving periop chemotherapy? This is something which I really have no answer to. So the important points to cover as it may improve survival. The trials as a whole show that the HR is 0.57, so it's super. But when you cut slice it thinner, you see that stage 1B to 2A actually the hazard ratio is 0.87. So the benefit may not be that much. Of course, the other three are going to lesser duration of treatment. It's just 3 cycles if you look at the keynote trial, and of course 3 cycles means less expensive as well. So I would favor it for all the other reasons. But you're worried about the possibility of progression because some patients will progress on immunotherapy, although the vast majority actually respond. And it is a technically demanding surgery. So surgery after even oral TKI, sometimes we give crizotinib and operate. So I have cases with IMF, inflammatory myofibrotic prostate disease, which are ALK positive and give crizotinib and operate. These are some of the toughest cases to operate. So any kind of neoadjuvant therapy actually makes the surgery more technically demanding. And also you're worried that there's an issue of morbidity because some of these patients will have a background of pneumonitis, and when you operate on them, the post-operative morbidity might be significant. So these are the other considerations. So you're a little bit concerned about stage 1B to 2B, whether you should be actually giving neoadjuvant. So this is one of the trials which the concern of the progression. So this is a meta-analysis of over 5,000 patients, included 8 randomized controlled trials and 3,000 patients from randomized controlled trials. They found that the progression rate was only 7.4%. But because of multiple reasons, including patients refusing surgery after starting or toxicity, nearly 7 to 23% of these patients actually did not end up with surgery. That means 1 in 5 patients did not end up with definitive treatment, and that's an important consideration. So again, the ESPO came up with a statement. Dr. Suresh said it is incidentally a Mallu by a long way off, actually. So they put up a statement saying that the benefit of neoadjuvant chemoimmunotherapy early stages, such as 1B to 2B, seems to be more limited, and the potential benefits must be carefully weighed against the risks, including possible toxicities. So it says that the title of the talk says, should neoadjuvant therapy be standard? But in the text, it comes down to saying that, okay, you have to use your judgment in using it. And also, important considerations, they are also concerned about the toxicities, complications of surgery. But it's come down. So earlier trials, a lot of data came out about the technical difficulties of surgery and potential complications. This is the largest analysis which I've seen with more than 5,000 patients. They found that actually the minimally invasive surgery rates were the same. The conversion rate of cornea was the same, and so also the R0 resection rate. And funnily enough, even after a lot of immunotherapy or neoadjuvant therapy, they had similar morbidity and mortality as well. So acceptable morbidity and mortality. you could give neoadjuvant therapy, but in early stages in the effect, it's like the art of medicine, as Buddha said. You have to judge, use your judgment on this. So one thing which you have to remember is, although the rates are similar, if you tell a surgeon to operate after multiple cycles of immunotherapy, it is technically demand. I recently operated a patient after 11 cycles of nivolumab from Delhi. We keep paid after 30 days, but 1.5 months later he's complaining of episodic breathlessness. I don't know whether it's something like radiation memory or surgery is induced pneumonitis. I don't know. So it is a lot of judgment. So any other indication, unresectable stage 3B was a no-go area for surgery, but we do get a lot of cases after chemoradiation and nivolumab, and again much more technically demanding, but we got rewarding results in such cases. So I'm surrounded by radiation oncologists. I'm glad JP is not here. He left in the morning. But here is the reduced role of radiotherapy based on all evidence. So no neoadjuvant chemoradiation for N2 disease. I would give neoadjuvant chemo for sure. The only place where I use it is in superior surface tumors without N2 disease. Port. I used to give, if residual lymph nodes after neoadjuvant chemotherapy, I would always set for radiation. But the recent port and port-C and the Lamar trials have said that there is no advantage. So the only place I use it is in positive margins. And as I said, N2 disease residual, there is again no rule. It needs to be analyzed a bit more for us to understand the nuances of why, which patient to take it. But currently, actually, there's much less evidence for radiation. So at the end of it, the surgeon's perspective after immunotherapies, this is something which I never used to do reflex testing. I used to work in Karimundackal. The patient didn't have the money for reflex testing, so I never used to send for it. But now, after the initial biopsy, we do send for EGFR allograft. Not the panel, but this much at least, because this is going to decide whether the patient can receive neoadjuvant chemotherapy or not. That's one major change. I give neoadjuvant chemo over neoadjuvant chemotherapy wherever possible. If the patient can afford it, that's a key marker in borderline resectable to avoid immunotherapy, and definitely in N2 resectable disease. One important change which comes is multi-station resectable N2 is surgical disease now. It's moved away from chemoradiation to surgery. And stage 1B to 2, I actually should have put it in grade. This I'm not really sure. I'm proponing, saying it should be primary surgery. But I had a conversation with the surgeon yesterday who was violently saying you can't put it in black and white. It's a grey area because there is a potential benefit for neoadjuvant chemo, and probably you should treat it that way. What I don't know, adjuvant therapy, I'm really not convinced whether immunotherapy is, and probably because the tumor is out, the immune system doesn't work that way. Where to use neoadjuvant versus perioperative, I really have no clue. Probably where the disease is a bigger burden, probably perioperative. And the role in EGFR positive disease, 35 to 40% of my patients are EGFR positive, so immunotherapy is on. So when they were excluded the trial, does it work in these patients? I really have no clue. That is good for thought. Probably you can give me an answer to this. Thank you very much.
Thank you, sir, for
Yep.
informative talk.
I will pass off as a comment in saying in an EGFR mutant, no role. No role. I mean, so let's be very clear. All the trials, including the AGR and the Keynote 6771 and Checkmate, they've excluded patients from this. So in an EGFR alt mutated, no role of immunotherapy, neoadjuvant adjuvant setting. You can, in the adjuvant one, we can give them Adora. In the neoadjuvant, we have Neo-Adora, but it's not really working.
Okay.
So my question to you was something different. Do you think you can convert an unresectable disease into a resectable disease by use of neoadjuvant chemoimmunotherapy?
Yeah,
Second, N3. I mean, N3 is, so N3 typically was outside the domain, but let's just say it's a contralateral small mediastinal lymph node. Responded beautifully. What are the harm? And you can take it out.
Yes. So
I just trying to fuel your ego.
Yeah. So as I'll follow my boss and say if it's not stuck to the, I can still take it out.
Yes.
To answer your first question, if it's unresectable, I've seen cases where after because of that, so unresectable, if there's a large field, sometimes my radiation oncologists also hesitate because they can't cover an entire field with radiation. There are cases in which they have given neoadjuvant chemoimmuno, and now at that point also it's still not shrunk to an extent where they get radiation, you're stuck. So I've gone in the resector, some of them have resector, at a critical point. So it's hardly 1 or 2 points in the whole chest where most of blood vessels or bronchus where it's unresectable and they respond that direction, it becomes resectable. So there are a few cases where we have done it. The second question is entry. The reason why we are hesitant about entry is the recurrence is always systemic, as in the node per se never usually creates a problem. Now, I have an operated patient with the advent of oral TKI and immunotherapy, where there's oligoprogression or oligopersistence and a continental sector. But that's after observing for a long time and being sure that they're not going to progress. Because I would, like you said, it's a case of judgment. If you jump in too early and the patient progresses in some other area, then it's a wasted surgery. So I'll wait for some time and see that that is a really isolated site where it's progressing or persistent, and I will offer surgery. Because I think it's a time when we have to tailor treatment, because the treatment duration is very long and each one has a role to play. We have to